ABT 450, Ambitibir and Dacibur with Berberin for hepatitis C with cirrhosis. Concept: interferon-containing regimens for the treatment of hepatitis C virus infection are associated with increased toxicity in patients who also have cirrhosis. We evaluate the interferon-free combination of the protease inhibitor with ritonavir, the NS5A inhibitor obitosvir, the nucleoside polymerase inhibitors Desabur, and the ribavirin in an open-label phase 3 trial involving previously untreated and previously treated adults with HCV genotype 1 infection and compensated cirrhosis.
Ensure that the equipment is prepared and check that the laryngoscope is working and the cuff on the tube inflates and deflates properly. Pre-oxygenate the patient with bag and mask ventilation for up to 1 minute before attempting to intubate. Standing behind the patient with the head in the sniffing the morning air position, with the left hand, insert the curved blade of the laryngoscope into the mouth over the right side of the
Methods: randomly assign 380 patients with Hall-Pugh class A cirrhosis to receive either 12 or 24 weeks of treatment with ABT 415. Ambitibir at once daily dose of 150 mg of BT 450, 100 mg of ritonavir, and 25 mg of ambitibir. Dacibur 250 mg twice daily and berberin administered according to body weight. The primary efficacy endpoint was sustained virologic response 12 weeks after the end of the treatment. The rate of sustaining virological response in each group was compared with the estimated rate with a telaprevir-based regimen. 47%, 95% confidence interval, 41 to 54, and non-inferiority margin of 10.5 percentage points, established 43% as the non-inferiority threshold. The superiority threshold was 54%.
Cut the endotracheal tube to length. Remove the connector. Note that the connection to the tube may be tight, and then cut the tube diagonally to make it easier to reinsert the connector. Replace the endotracheal tube connector. The fitting should be tight so that the connector does not inadvertently separate during insertion or use. Ensure that the connector and tube are properly aligned so that kinking of the tube is avoided. Connectors are made to fit a specific size tube. They cannot be interchanged among tubes of different sizes. When inserting the stylet, it is essential that the tip does not protrude from the end or side hole of the endotracheal tube to avoid trauma to the tissues. The stylet is secured so that it cannot advance further into the tube during intubation. Select a blade. A 0 is typical for preterm babies and a 1 for term newborns. Attach it to the handle by holding the blade and handle parallel. Place the hook of the blade over the bar of the handle and pull downward along the plane of the handle.
Using the bogey.
You're basically going to do high flow oxygen, a nasal cannula, and so we kind of passive oxygenation as you start to do the intubation.
I'm gonna slide this out from under your head, ma'am, okay?
So what we're going to do is we're going to go ahead and do the intubation with the storks. However, the intubator is not going to be able to visualize it, and we're going to watch the screen. He's not, but he's going to use the bougie. So we're going to actually watch him do a bougie intubation.
Chelsea, the autometer is going in. Not over there on the top.
Results: a total of 191 of 208 patients who received 12 weeks of treatment had a sufficient virological response and post-treatment week 12 for a rate of 91.8%, 97.5 CA, 87.6 to 96.1. A total of 165 of 172 patients who received 24 weeks of treatment had a sufficient virological response at post-treatment week 12 for a rate of 95.9, 97.5%, and 92.6 to 99.3. These rates were superior to the historical control rate. The three most common adverse events were fatigue of patients in the 12-week group and 46.5% of patients in the 24-week group, headache in 27.5% and 30.8% respectively, and nausea in 17.8% and in 20.3% respectively. The hemoglobin levels was less than 10% for the elderly in 7.2 and 11 of patients in the respective products. Over 2.5 of patients discontinued treatment owing to adverse events.
Air track here. Okay, we're just preparing this. So we went ahead and moved up the tube. We're using 7.5. This would be nice and you have to slip through. Okay. There's here. No. On him. Check here.
I did.
Are we ready for accommodation?
The injections not melon, yeah, we're ready.
Yep. In 100 seconds. You have your secondary airway ready.
Sequence intubation. This patient is an overdose, so she's not all that tachypic, but she's not protecting her airway all that well. So what we're going to do is we're going to intubate her to protect her airway. In preparation for the intubation, what you need to do is make sure that the entire head of the bed is ready to go. And that includes a 100% non-rebreather on the patient, suction set up so that you can suction the patient. Suction should be turned all the way up to full and should not be on intermittent. In addition, you need bag off mask set up and with air flowing to it. The capnometer needs